Good morning. Thank you for the introduction, although I didn't understand any of it, but it's so nice to be here. I'm very honored to speak to you today about a topic which is very dear to my heart, medullary thyroid cancer. I want to thank you all for the nice invitation to come attend. Thyroid cancer is becoming more and more common, especially in the United States. In 2011, over 48,000 new cases were diagnosed in the United States, making it the fastest growing cancer in both men and women in the U.S. One important thing that has happened over the last year is that the American Cancer Society made a big commitment to do research on medullary thyroid cancer, and they set up this consortium or group of 12 investigators and put forth $10 million in order to find new therapies for medullary thyroid cancer, and also to study multiple endocrine neoplasia type 2 or MEN2. And this is just, if you go to their website, you can read more about it. I have the great honor of leading this team of investigators in the United States over the next 5 years. So medullary thyroid cancer comprises 3% of all thyroid cancers and arises from the neuroendocrine cells, or the C cells within the thyroid. The prognosis is much worse for these patients than it is for papillary thyroid cancer, which a 30% 10-year survival. And although medullary thyroid cancer accounts for only 3% of thyroid cancers, it accounts for 14% of thyroid cancer-related deaths. Now, I put this slide up because this picture was given to me by one of my partners, Jim Starling, who is now retired, and it is a picture of a patient he operated on in 1987 with medullary thyroid cancer. And if you look at this thyroid, you can see that there are two tumors both on the left and right side of the thyroid. And what we knew about medullary thyroid cancer when he removed this thyroid in 1987 was that approximately 75% of patients had sporadic medullary thyroid cancer. That is, they presented usually with one tumor with a later onset in life. However, 25% of patients presented with inherited or hereditary medullary thyroid cancer, and they often had bilateral or multifocal tumors, and the disease occurred much earlier in their life. Now, we now know that hereditary or inherited medullary thyroid cancer can come in many different varieties, such as multiple endocrine neoplasia type 2A or MEN2A, where all patients develop medullary thyroid cancer, about 50% develop pheochromocytoma, and about 25% hyperparathyroidism. MEN2B, again, all patients develop medullary thyroid cancer, and some develop pheochromocytoma. And then lastly, familial medullary thyroid cancer, or FMTC, in which medullary thyroid cancer occurs by itself, but is found in 4 or more relatives. Now, I trained at Johns Hopkins Hospital, and when I was a trainee, I met a gentleman named Greg Bulkley who had an interest in medullary thyroid cancer. And for the trainees who are attending today, when I was a surgical resident, we were required to do 2 to 3 years of laboratory research. And when I went to Johns Hopkins, I did not know what I wanted to do. And Dr. Bulkley came up to me and said that you will do research on medullary thyroid cancer. So I said, okay. And he introduced to me this gentleman, Steve Balin, who was an endocrinologist at the time, and he was trying to find what mutation caused medullary thyroid cancer or inherited medullary thyroid cancer. And you can see in the early 1990s, he had published some very important papers in the journal Science studying how or what gene was responsible for medullary thyroid cancer. So when I went into the laboratory as a surgical resident, I talked to Dr. Balin, and initially my project was going to be to look to see what gene caused medullary thyroid cancer. Unfortunately, before I started in the lab, they discovered the gene that caused medullary thyroid cancer, which we all know is to be the RET proto-oncogene. and Sam Wells' group in Washington University in St. Louis, along with many other surgeons who were on the investigative team, found that the mutations in RET caused inherited MEN2A and familial MTC, and later discovered it also caused MEN2B. So this is the gene RET, which causes hereditary medullary thyroid cancer, and it's found on chromosome 10. And the nice thing about this particular discovery was that if a patient inherited a RET mutation, we knew with 100% certainty that they would get medullary thyroid cancer. So the mutation predicted exactly what would happen clinically. So this was the perfect gene in which for us to discover and also to come up with a treatment, because if we could then test patients for the mutation, we knew for certain that they would get the cancer, and we would suggest that they get intervention. So then research by Dr. Wells and others subsequently identified that each specific mutation listed here in this figure for the RET gene, that a specific mutation found at a certain location caused either MEN2A, 2B, or FMTC, and that depending on which mutation you inherited, the mutation would predict how aggressive the medullary thyroid cancer could be. And so based on the specific mutation, these recommendations were made in 2001, and these have been revised since, where if you had a mutation here, level 3 mutation, which is a very aggressive RET mutation, that the medullary thyroid cancer was very aggressive, if an individual inherited this mutation, they would, you would recommend a total thyroidectomy before age 6 months. If they inherited a level 2 mutation, that is mutations in these codons, that we would recommend that thyroidectomy occur before age 5, and then a level 1 mutation, which is the least aggressive mutation, we'd recommend total thyroidectomy before age 10. So what we did is, based on the discovery of the RET gene and the recommendations to perform prophylactic surgery in order to prevent medullary thyroid cancer, we recently did this study, and this study was actually done by a medical student, Kevin Chapet, in my laboratory, where we wanted to see if you had your surgery appropriately at the right age, did it improve your disease-free survival? And so what Kevin did is he looked at a cohort of patients undergoing prophylactic thyroidectomy for medullary thyroid cancer, and we looked at patients and divided them into two groups, whether or not they had age-appropriate prophylactic surgery, and we compared those patients to those who had thyroidectomy after the recommended age. And again, the recommended ages are listed here, but also on the chart that I had provided based on the level of RET mutation. And this is what we found. We found that if patients had what we call age-appropriate prophylactic surgery, you can see that the disease-free survival is 100%. So therefore, if you follow the guidelines, patients do very well. However, in patients who had surgery after the recommended ages, you can see that their disease-free survival is only 50%. So this is one that I believe one of the first series to really show that indeed, if you follow the guidelines for inherited medullary thyroid cancer, patients do very, very well. So in essence, based on the work of Dr. Wells and others, we can cure hereditary medullary thyroid cancer with a prophylactic thyroidectomy, which solves this problem for 25% of patients with medullary thyroid cancer. However, the problem for us today is that what do we do with the patients with sporadic medullary thyroid cancer that make up the majority of the patients we will see in our clinic? So this is one patient that I saw a few years back, a 27-year-old student who presented to her doctor with an earache for 2 days, and she had a history of TMJ syndrome, and she was planning on taking an airplane flight the next day, and she wanted to see her doctor to get some medication for this pain. And when the doctor examined the patient, found that there was earwax in the ear, but you can see, if you can read this, the doctor said, while I was talking with the patient, I noticed that her left neck was bigger than her right. And he examined the neck and found a left enlarged thyroid gland, and in fact ordered an ultrasound, which showed a 4.9 centimeter thyroid nodule and a 4.1 centimeter lymph node. So what I'm going to talk to you a little bit about is the recommendation for treatment of patients with sporadic medullary thyroid cancer based upon some guidelines that we recently wrote for the North American Neuroendocrine Tumor Society, published in the journal Neuroendocrinology, as well as published in The Oncologist and a recent review article we have written. So important, when you treat patients with medullary thyroid cancer, it is very important to make the diagnosis early. And how we make the diagnosis is with fine needle aspiration. And we would, in this patient who I presented to you, we would biopsy not only the thyroid nodule, but we would biopsy the lymph node in order to determine that the lymph node contains metastases. We do FNA right in our clinic. Right outside the clinic, we process it, and we're able to give the answer to the patient within minutes of the biopsy. And when we looked at our outcomes on utilizing fine needle aspiration for patients with thyroid cancer, which we published in the Annals of Surgical Oncology, and one of our fellows, David Greenblatt, did this study, we were able to compare patients who had fine needle aspiration for the management of the thyroid cancer versus a group of patients who did not. And we did this study at the time because we had one surgeon in our group who did not necessarily believe in using fine needle aspiration for all patients with thyroid cancer. So what we found when we did fine needle aspiration, we had 98% patients had optimal management of their cancer, versus when fine needle aspiration was omitted, only 54% of patients had optimal management. And so for this patient that I presented to you with a graduate student, we did a fine needle aspiration, and you can see this aspirate shows a lot of blue round cells. And when we did Congo red staining, which is classic for medullary thyroid cancer, it all turns red, clinching the diagnosis of medullary thyroid cancer. So before we operated on this patient, we did the fine needle aspiration. We obtained the serum calcitonin and CE level. We also did a red screening, which we do on all patients with medullary thyroid cancer. And we also screened for pheochromocytoma with plasma metanephrines and hyperparathyroidism with calcium and PTH. And then we did staging with a CT scan of the neck, chest, and abdomen. So for this young woman, we found that her calcitonin was markedly elevated at 9,000. Her CEA was also elevated, but her calcium, PTH, and metanephrines were all normal. And she ended up not having a RET mutation, but just the sporadic medullary thyroid cancer. So this is her CT scan, which you can see this is the large tumor here in the left lobe of the thyroid causing tracheal deviation. This is this large lymph node here by the carotid. You can see that this large lymph node encompasses the carotid artery right there. So importantly, when you have treating a patient with medullary thyroid cancer, you have to do an FNA, you have to have a high level of suspicion, and you need to do the calcitonin and CEA. We actually examined and reviewed whether or not we should use calcitonin and CEA on all patients with thyroid nodules. And based on the studies both published in Austria and Italy and others, we do not use calcitonin and CEA on all patients with thyroid nodules because it's not cost effective, only when we have a suspicious FNA that we cannot readily diagnose medullary thyroid cancer. So once you make the diagnosis of medullary thyroid cancer, it is very important to do the right operation. And so as we discussed before, the best operation for medullary thyroid cancer, that if you have the hereditary type, you want to do a prophylactic thyroidectomy. But if you have a patient who has sporadic, like this graduate student that we're discussing today, I believe the right operation is a total thyroidectomy with a central lymph node dissection bilaterally, and we would consider a modified radical neck dissection. In the patient I presented, we would definitely do a modified radical neck dissection on the side with that big lymph node is present. Another study we did, again by our fellow David Greenblatt, is we wanted to look at if initial lymph node dissection increases the cure rate in patients with medullary thyroid cancer. So this is a small series that we published, and we indeed did find that. If you do the operation correctly, the chance of recurrence is much lower. And so this is the operation that I did on this young woman here. I did a total thyroidectomy here to resect this mass. We did a bilateral central lymph node dissection, and she had a lot of lymph nodes on the ipsilateral side, another positive on the contralateral, a modified radical neck dissection to include high level 2 as well. And in this case, we had to auto-transplant 2 of her parathyroid glands to her sternocleidomastoid muscle. And this is a picture of the pathology here, H&E, and then we did immunohistochemistry for chromogranin A, which was positive, confirming the diagnosis of medullary thyroid cancer as expected. So I think that in a patient that presents with sporadic medullary thyroid cancer, the minimum operation is a total thyroidectomy and bilateral central neck dissection, and a modified radical neck dissection for those who present with positive lymph nodes in the lateral compartment or are at high risk to develop lateral lymph nodes. But interestingly, despite this, we have known this for years, but still in the United States, most surgeons are not doing the right operation. This is a paper published by Electron Kibabu, who was at UCSF at the time when he published this, now is in Washington, D.C. When he reviewed the SEER database, that is the database that contains a sampling of patients treated in the United States with cancer, and he looked at patients with medullary thyroid cancer, and those with stage 3 and stage 4 medullary thyroid cancer found that if you looked at how many patients actually had a lymph node dissection, only about half the patients in the United States had lymph node dissection, which means that only about half the patients in the United States were getting the correct operation. So it's very important for endocrine surgeons in the United States especially to emphasize to all surgeons what the right operation is and to get them to do the right operation or refer them to centers that will. Another important point in treating patients with medullary thyroid cancer is that sometimes you will not be able to cure them, but you still need to palliate their symptoms. And often we don't consider surgery for palliation, but I would submit to you that surgery plays a very important role in palliation. So this is a paper that I published when I was still at Johns Hopkins with the group there, when we looked at the long-term outcomes of patients who underwent surgical palliation for metastatic medullary thyroid cancer. And then these specific patients who had symptoms of either airway compromise or SVC syndrome, arm pain, they all went resection of focused areas of medullary thyroid cancer. And we found that their symptom-free survival after palliative surgery was actually quite good out to 10 years. So even if the medullary thyroid cancer is unresectable or uncurable with surgery, there are times where we have to do operative therapy in order to make the quality of life for these patients good and relieve symptoms. So lastly this morning, the topic I wanted to cover is that in patients who present with inoperable medullary thyroid cancer or metastatic medullary thyroid cancer, it's important to participate in clinical and research trials in order to find a new treatment for these patients. So part of my job over the last 10 years has been to study medullary thyroid cancer in the laboratory. So I spend about half my time in the operating room and about half my time in the laboratory. And we have been studying the pathways which control the growth, the hormone secretion, and the metastatic ability of medullary thyroid cancer. And by understanding these pathways, we hope to develop new therapies for medullary thyroid cancer. And so I just want to spend just about 5 minutes telling you about some of the exciting research that we've done and the possible new therapies that we have for medullary thyroid cancer. And it's based upon my research studying this molecule called Notch. Now, Notch is a receptor that's found on the cell surface. And over the last 10 years, our group has shown that this Notch pathway is a tumor suppressor in neuroendocrine cancers, including carcinoid, medullary thyroid cancer, and pheochromocytoma. So we have generated a lot of data showing that if you could turn on Notch in patients with all of these types of cancers, it could potentially inhibit the growth of the tumor, and also palliate hormone secretion from these tumors. So what we then asked ourselves is that, are there any drugs that currently exist which can turn on Notch? And within the National Institutes of Health in the United States, we know that there are greater than 140,000 compounds which they have in a bank, which have been studied in humans, which we know if they're safe or not. And so what we wanted to do is figure out, is there a way to determine if there are any existing compounds that turn on Notch and can be utilized for medullary thyroid cancer? So in order to test this, what we took advantage of the property, this is the Notch signaling pathway, and to turn on this pathway, the Notch protein has to bind a molecule called CBF1. So we created this special type of assay or cell, utilizing a neuroendocrine cell, which we took this binding site of Notch1 and fused it to a gene that made light and introduced this in a cell. So therefore, we created this cell that if we put a drug on the cell would light, and then it would tell us that that compound made activated Notch. So what we did at our institution, and this is work done by a surgical resident in my laboratory, Scott Pinchot, he utilized our small molecule screening facility, utilizing a whole bunch of robots and technology where they could take our special cell and treat the cells with thousands of drugs using these computers and robots. So within 1 week's time, we could examine 7,000 compounds quickly and determine if any of these compounds activated Notch or turned on light in these cells. And what we started with is 7,000 compounds which have been called the known bioactive library. So these are drugs which are already been tested in humans for other diseases, but may have probably never been tried for medullary thyroid cancer. So this is what we found, is that of the 7,000 compounds that we tested, we found 27 which turned on Notch, and 2 drugs which turned on Notch to very high levels. One of them called VPA or valproic acid. So David Greenblatt, again, took the drug we had discovered, valproic acid, and found that it indeed turned on Notch in both carcinoid and in medullary thyroid cancer and killed the cancer cells both in the test tube and also in animals. So therefore, based on our research, we did a phase 2 clinical trial in patients with neuroendocrine cancers utilizing valproic acid, which is something that we treat epilepsy with in the U.S. So we enrolled 7 patients in this clinical trial, which we treated them with 500 milligrams twice a day of valproic acid to a level of 50 to 100, which is the level that we would treat patients with epilepsy. And then we evaluated them every 8 weeks, and this was done in conjunction with one of our medical oncologists, Kyle Holan. And this is what we found, is that in this clinical trial for these 7 patients, that and this graph shows their change in tumor markers. 2 patients did not respond to the drug because their tumor continued to grow. However, 5 patients did have some response. As you can see that this is a change in their tumor markers, and these 3 individuals had a significant change in their tumor markers with the clinical trial with valproic acid. So hopefully that with this small clinical trial and these positive results, we hope to expand this to a larger trial in the future. So in summary, when we optimize a treatment for medullary thyroid cancer, it's important to make the diagnosis, do the right operation, palliate symptoms, and consider clinical trials in patients who are not candidates for surgery. I just want to end my talk by crediting, this is my lab here of the individuals who work with me. A lot of students, residents, and we have some faculty who work in my lab. And just acknowledge the collaborators that we have at our institution, other institutions, and then the grants which support our research. Again, it's quite an honor to be here at your Congress, and I thank you for the opportunity to present to you our work, and I'd be glad to answer any questions. Thank you very much.